Good afternoon and welcome to today's program titled It's Not About Food, It's About Feeding. I'm Gary Enos, editor of Addiction Professional magazine. Today's program is sponsored by Sierra Tucson. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few details we'd like to go over. Please use the Q&A area below the slides to submit a question at any time during today's presentation. You do not have to wait until the end of the program. To download a copy of the presentation, please click the link in the Resources tab to the right of your slides. If you have any technical issues during the program, please click the red Help button to troubleshoot the issue. I have a special note about CE credit. To get your CE, you must watch the program all the way through the Q&A section at the end of the presentation. Do not leave the console. The site will automatically redirect you to a survey. This survey must be completed in order to generate your CE certificate. For those watching in a group, please download the group submission guide in the Resources tab and follow the instructions provided. Please note that CE credit is not available for the archived webinar. It is only available for the live event on February 15, 2017. Finally, join our conversation on Twitter by tweeting with the hashtag APLiveWebinar. At this time, it is my pleasure to introduce our speaker. Dr. Tena Moyer serves as the Associate Medical Director for Sierra Tucson, with a primary focus on the development of the Eating Recovery Program and addressing acute clinical patient concerns. Dr. Moyer completed her undergraduate degree in independent studies at Occidental College in Los Angeles. This degree combined majors in art and biology, resulting in her work as a medical illustrator prior to attending medical school. In the continuation of her education, Dr. Moyer attended University of Southern California Keck School of Medicine and did an internal medicine internship at USC Los Angeles County Hospital. After working several years as a general practitioner, Dr. Moyer realized that she was particularly fascinated by psychiatric illness and returned to a psychiatry residency at the University of Arizona. Thank you, Dr. Moyer, for taking the time to speak with us today. And with that, the audience is yours.
Hello and welcome to this webinar. I'm looking forward to spending the next hour with you. I'm going to forewarn you that I'm kind of a technology troglodyte, so if there's moments of frustration with my slides, I have my trusty helpers here. What I want to focus on today is looking at the meaning of eating disorders, the meaning of food and the feeding process. They are actually two different things. And we tend to view them as, being synonymous with one another, but in fact they aren't. ED patients are probably notoriously some of the most difficult to treat. And a lot of that is because the wounds that result in an eating disorder in an adolescent or an adult have actually occurred very, very early in development, prior to a time when there was any consciousness on the part of the child around food or feeding, and certainly before they had any vocabulary around it. So when we're working with these patients, it's important that we understand that we're dealing with a very primitive intrapsychic or unconscious state. Okay, I'm having a slide moment here. There we go. So let's look at food. Food has meaning and value that has absolutely nothing to do with nutrition. Have you noticed when you talk to your ED patients, they're not interested in nutrition. They're interested in the amounts of food they will or will not eat. The only time nutrition comes into play is when you're looking at things like fats and carbohydrates. That is because this is not a nutritional issue. This is about managing their body, their internal body experience, as well as the meaning that foods have taken on. I want to point out that when you think about mother's milk, and I mean literally mother's milk, what's in it? Well, there's obviously protein, but it's high in fat and it's high in glucose. So I don't think it's an accident that those are the foods that our patients want to avoid. So food functions as a means of emotional communication. What is, and we can think about the child, what is the child telling the parent, but we need to recognize that we are now, as treatment professionals, in the parental role. So what is the patient telling us about their emotional state in terms of their food choices and their feeding behaviors? Food can be either a soothing resource or a stressing resource. That, of course, is going to depend upon A, the meaning that the patient assigns to the food, and B, the meaning that food had in that patient's family of origin. Food can be a source of including or excluding. For example, I had a very, very overweight patient, a compulsive overeater, who lived with a mother who was bulimic and a sister who was anorexic and a brother who ended up marrying an anorexic. This was an eating disordered family. She was the oldest of three, and what happened is mother, I suspect, had a lot of difficulty managing this pregnancy because all of a sudden her body was distorted and her appetite was increased. So what would happen is this child, the oldest child, was not allowed to eat foods that the other children were allowed to eat. So therefore the conflict for the patient becomes, I want to get mine and it's not fair. And for the mother, it's a way of excluding this child who had probably caused some kind of an intrapsychic conflict during the pregnancy. It's a way of excluding her. Food is also a message of autonomy and authority. We're going to touch on that in a minute, but it's important to remember that food is about not only about the nutritional piece of it, but it's also about the child learning how to feed themselves and the child developing independence and autonomy as a psychological being. Children are often rewarded and punished with food, so that it can be a source of it takes on meaning in that context. If you're good, we'll go get ice cream, and if you're bad, you can't have dessert. It is a social binder. There is not a culture in the world that does not use food as a way of holding a community or a family together. That's when I say it's a means of including or excluding. How is this child? What is their experience? We're seeing the adult, but imagining the child self of that adult. What was the message that child got about being included or excluded from the family system? My patient that I mentioned earlier was excluded. The younger siblings were included. Struggles around food and feeding are common in development with young children because it's one of the ways a child can first establish boundaries and autonomy via preferences, refusals, etc. Now, if you have a parent who then cannot tolerate autonomy in that child, then what's going to happen is the food becomes a power struggle. And the conflict over eating or not eating, or eating this food or not eating this food, becomes a major family dynamic in general, but also a major relational dynamic that is going to recapitulate over and over again in that child's life as they grow up. The other thing to remember is that food is a tool. It helps patients manage affective states that they don't have other means to manage. And we'll talk about that a little bit more later. So, there we go. I'm sorry, I don't think my whole slide came up, so I will just tell you what it shows. Basically, we need to recognize that feeding behaviors represent a synergy of both conscious and unconscious experience. The unconscious experience is what occurred when that child was younger. The conscious experience is the behavior that the patient is behaving in now. But of course, in any adult, the conscious and the unconscious are equally as active in behavior and moods and that sort of thing. There's the biological piece of it, which we need to remember. some of this is what we would call epigenetics. For example, the Irish potato famine, notoriously known, it shows up many generations down the line, where there's an increase in mental illness in the offspring, many generations later, of those great-grandparents, great-great-grandparents, those ancestors that suffered starvation. And we actually see that happening across multiple situations and multiple countries and ethnic groups. So it's not a cultural process. Basically what it means is when the body is stressed or when the psyche is stressed, it does not change the genes, but it can change the way the genes are expressed. And that we may be seeing, if you have a patient and 200 years ago their family was starving, how much of that mental illness represents the consequence of that starvation experience for the overall genetic legacy of this family. We need to remember there's also the physiological aspects of it, like acid-base, nutrients, gastrointestinal function, hormones, that sort of thing. And we need to remember that the gastrointestinal system is innervated by both the sympathetic, which is an activating nervous system, so the sympathetic nervous system, and the parasympathetic nervous system, which actually brings us back down to sort of a baseline homeostasis of feed and breathe, or rest and digest. There's different ways of talking about it. From a developmental standpoint, the child is developing motor skills as they grow up physically. They're making all kinds of wonderful neuronal connections, in this early brain. And so that infants are actually born with a low density of neuronal connections. I'm not going to give you numbers because I don't know them, but they are born with a low number of neuronal connections through early development, and I'm talking about from like ages 0 to 6 or 7, they have a massive increase in neuronal connections, so that by the time, though, that they're 15, they have pruned away those which do not seem necessary or are not helpful. So you actually have higher neuronal density in a 7-year-old than you do in a 17-year-old. Why is this important for us? It's important because what are our patients learning in those very early developmental years? Now, one of the things that they're learning is clearly messages around food, feeding, and body. So those pathways that we struggle against when we're treating the adults have been there for almost a lifetime. We're not going to overcome them by a month or 6 months in treatment. Eating disorders, by definition, take long periods of treatment simply because what we're trying to do is rewire the brain. From a psychological standpoint, without going into too much here, but when we look at the 4 psychoanalytic schools of thought, there's drive theory, which was Freud, which has to do with the management of instinctual drives versus, what we're allowed to express versus what we're actually feeling. So that's the concept of the ego, the id, and the superego, which we will touch on later. There's ego psychology, which is how does this person come to know themselves and come to manage the conflicts, the internal conflicts, as opposed to what's allowed in the outside world. Both of these have to do with defense mechanisms that we develop. The concept is that the ego develops defense mechanisms in order to manage sort of the interface between the internal life of the patient and the external world. Heinz Kohut developed the concept of self-psychology. Why is this important? Self is about who we know ourselves to be. And who we know ourselves to be is something that we learn as we grow up. We learn that we hate piano, but we love guitar when we're 8 years old. We learn that we're really good at soccer, but we really suck in choir. And therefore, our preferences are based on our successes. And this becomes, over time, consolidated into a healthy self that can sort of navigate life with reasonable success. None of us get all of it perfectly, but we do a good job. We develop healthy enough relationships. We're functional in school. We're functional in relationships. And finally, object relations. Object relations is about how we basically experience the presence of others, I'll put it that way, in our lives, both our conscious and our unconscious experience of them. Object relations is very much about what feeding behavior is, food and feeding. I want to be clear that all of these are relevant, but object relations is where the real feeding issues can often come in. We see these adults who arrive in our offices fully formed, but the question we have to ask ourselves is, what does that adult personality structure tell me about their childhood experiences? And really, that's what I'm talking about today. So let's start with the biological. Where is my button? There it is. Let's start with the biological. The biological, first and foremost, is we have one job, and that is to survive. And the reason we have to survive is because we have to pass our genome on. This is older than vertebrates. We're talking single-celled organisms here. So our brains are wired back to infinity with the biological imperative to survive. He who dies with the most genes out there in the world wins. So I'll give you, for example, Genghis Khan and his male relatives, sons and brothers. When they looked at Y chromosomes across Asia and Europe and Southeast Asia, what do they find? They find this Y chromosome that actually represents the Genghis Khan family. So that was a very successful family in terms of survival. The brain is wired to keep us alive, first and foremost. It's important to remember that survival behaviors are reflexive. They are not conscious. It is only as the child matures and the adult has experience in life that those strategies of survival become conscious strategies. But to begin with, it's a completely biological phenomenon of which there is not a conscious component until you're old enough to have a conscious component. So, looking at the nervous system, I want to look at what happens when there's a threat to our survival. The first question is, what is a threat? A threat is anything that threatens survival. So it could be predation, it could be starvation, and it could be isolation. That is, we are dependent on one another for our safety. We're not big, we're not strong, we're not fast, we don't have big teeth and claws. What we need is one another to protect us. So social isolation is actually a threat to survival. The important thing in this slide I want to point out is we have this threat. It's the lion in the grass, or euphemistically speaking. There's an activation of the sympathetic nervous system, which results in the fight-flight response. Okay? I'm just pointing out that catecholamines, actually just think of it as adrenaline. That's sort of a doctor word because it makes me feel smart. But really what we're talking about here is adrenaline. Dopamine and cortisols are released. I want to ignore cortisols for now, but I do want to look at the adrenaline and the dopamine piece. The bottom line, though, with sympathetic activation is that the fight-flight response is triggered. If we look at epinephrine, what's happening? Well, basically what it's saying to me, my body is saying to me, you need to run away or you need to fight. So I need to activate all the resources in my bodies towards the focus of one of those ends. And the stuff that doesn't help me survive does not need the blood flow. It doesn't need the oxygen. It's not relevant because if I don't feed my muscles, I'm going to be dinner, in which case I really don't need to be digesting my own dinner. So it's going to do things like increase heart rate, respiratory rate, blood pressure. You're going to expand the capillary beds in your muscles and your skin so that your muscles get oxygen and your skin can cool you off, and so on and so forth. What happens simultaneously is the gastrointestinal tract is shut down because you really don't need it at that moment. So, you know that saying of like, oh my goodness, I was so scared that my mouth was dry. It basically decreases secretions both orally from the salivary glands as well as along the GI tract. it decreases absorption, and it decreases motility. Hence, I'm going to point out that we have a lot of complaints of constipation. We also do diarrhea, which I'll talk about in a minute, but constipation in anxious people because their GI system is shut down. The effects of dopamine I want to linger on a little bit more. There we go. I've listed just a few of them here. Yeah, there it is, coming up. There's actually a lot of effects of dopamine, but I want to focus on those aspects that can help us understand eating behaviors, but also can help us understand substance abuse. Dopamine, we tend to think of it as the pleasure molecule. It's really not a pleasure molecule. What it does is it motivates us to seek pleasure and to seek soothing. So what happens, for example, if I'm an addict, if I'm an addict, what do we tell our addicts? Stay away from your old environment because they're going to get cued and they're going to drive by that corner where their dealer always hung out, and they're going to drive by that house where they used to party with their friends, and so on and so forth. Every time they get an environmental cue, they get a shot of dopamine, which then motivates them to seek that drug which gave them pleasure in the past. So the important thing, and they actually get less dopamine when they finally get that drug of choice than they do as they're cued to seek it out. So the motivation and seeking behaviors are really important. It does, you'll see it initiates motor activity, well, because if you're going to seek things out, you better have your muscle activity coordinated. It affects cognition and memory. Why is that important? Because, we're laying down those neuronal pathways very early. And and in order to do that, we've got to have sort of the brain talking to itself and storing memories so that we can get those pleasurable things, whether it's a tree that's full of ripe peaches every year or whether it's, a dime bag of heroin. It also has a lot to do with regulating social function. And this is important in particular because what do human beings do for soothing when their sympathetic nervous system is activated? They seek soothing through the social community. That's what mammals do, and that's what humans do. Another important thing, though, as much as that the dopamine is involved in the pleasure and reward system, it also motivates biological beings like us to avoid unpleasurable activities. What does that mean for us? Well, if every meal was spent with family arguments and hostility, who wants to sit down to a meal? If every meal is met with, you can't eat that, you need to eat more of that, you shouldn't eat that, oh, look at how much weight you've gained, you're going to avoid food. So we need to remember, though, that, we're thinking, oh, dopamine's getting released. That's the pleasure principle. It also helps people or animals avoid unpleasant, threatening, dangerous experiences so that when we're actually asking our patients to eat and we're asking our patients to show up and have a meal at the table with their fellow patients and their staff members, we are actually on a dopamine level, asking them to engage in behaviors that they perceive as threatening to them in some way. It's not conscious, but that's the wiring that has taken place in the brain. If we go back to, there we go. Okay, here we go. We're back to the diagram that I started, but here I'm expanding on it a little bit. There's a threat. The sympathetic nervous system is activated. There's a fight-flight response. Very important here. This is mediated by the same neurotransmitters, adrenaline and dopamine, among some other ones. We need to remember that in human beings, it's actually not a fight-flight response. It's an anger-fear response. That anger and fear are actually the same emotional, from a neurochemical perspective, they are the same experience. It's just that our brain names this as anger or names it as fear. Okay, but it's the same thing. What happens then is with the dopamine output, there is a motivation to seek soothing and safety within the community, and then the person goes over to mom and dad or to aunt and uncle or to their friend group, and they soothe each other. So think of a bunch of monkeys grooming each other and pulling like little fleas out of each other and doing that sort of thing. We're going to engage in soothing behaviors with our social group. When that happens, the sympathetic system is deactivated and there's a reactivation of the normal parasympathetic feed and breed system, okay? The other thing that's happening is there's an oxytocin release. Everybody's heard about oxytocin as this magical little love chemical, but really what oxytocin does, among other things, is it establishes attachment and bonding. That's not all that it does, but it's important to I want to be clear that it basically is helping lay down pathways of attachment and bonding and finding relief in the companies of others. Now, what's interesting about this is oxytocin does not necessarily promote a positive bonding experience. There was a study out of NYU, I think one of them at any rate, in which they gave men a bunch of oxytocin, and they, from a nasal sniffer, whatever it's called. You can't do it with women because of uterine cramps and milk letdown, but you can do this with men. So what they did is they had a group of men, and they gave all of them questionnaires about mother. What was your mother like? What was your relationship with mother like? And then after they filled out the questionnaires, they gave them oxytocin, and I think it was for a month off the top of my head. And then they came back and they gave them the same questionnaires. Well, if oxytocin is a love chemical, then the fantasy would be that everybody's memory, recall of their mother was more positive. But what they actually found is that while those men that identified a positive relationship with their mother prior to the oxytocin treatment actually had a stronger recall of a positive relationship with their mother. But the men who had a negative recall of their relationship with their mother had a more strongly negative recall of their relationship with their mother. This is important because what it tells us is not that oxytocin is the love chemical, but that it's the attachment chemical. And what it will do is it will amplify the experience of either a positive or negative attachment experience. So there's a lot more research being done on that, but it's important to recognize that oxytocin isn't the love bug, love potion number 9. It's really about relationships. It's not about love. And remember, having said that, whatever we grow up with as love from our parents, whatever that looks like, that's normal. If you grow up in a household of cannibals, cannibalism is normal. If you grow up with an alcoholic, abusive father, then alcoholic, abusive men feel loving because that's your template for what a loving relationship is. Now, what happens? There we go. What happens when, little girl runs to mommy and she's crying and upset, and mommy says, "Oh, what's wrong?" And she says, "The dog growled at me," and mother holds her and soothes her and sort of or turns off the sympathetic system and brings back the parasympathetic online. That's great. But what happens when mom's a drunk and she says, "Get out of here. Don't bother me now"? What happens? Well, that kid is still in sympathetic activation, right? Except that now the protector has become a predator, not because mother is necessarily abusive or sadistic, but simply because mother has now become a source to amplify the sympathetic response rather than to soothe it. So if safety and soothing are rebuffed, and there's this persistent amplification of the sympathetic system, then the kid is stuck in a cycle of sympathetic activation with no relief. We learn to soothe ourselves because we have these parents who soothe us. and we incorporate their techniques into our soothing system. If we don't have parents who are soothing, then we will not incorporate a self-soothing system. We're not able to do it. We will find ways to soothe ourselves because nobody can stay in a sympathetic state. But we're gonna find those things. We're gonna choose those self-soothing resources. We're going to choose from a child's toolbox and with a child's skill set. We're not going to choose with, the healthy mind of an adult who's been in therapy for 10 years. So whatever works for the kid is fair game. We need to remember that. They're doing the best they can. This is, when we talk about this, that where the parent or the caregiver becomes actually predatory in terms of sympathetic activation, we need to recognize that when we create a team of caregivers, we are going to be recapitulating for that patient the experience of the family of origin. And it has nothing to do with whether our members are like members in their family of origin. Remember, these templates are laid down a long time ago. So when that oxytocin kicks in because they're bonding with their treatment team, if they have a negative or a threatening experience of bonding, then that's how they're going to feel with us. And just stepping on, touching on this, I didn't quite mean to get to that. I'm going to back up here. Let's go. Okay, one other thing about this is, as I said, that fight and flight represent an anger and a fear, emotional state, affective state. One escape from that fight-flight is the freeze state. This is actually the most archaic of the nervous system responses to threat. We're talking like fish here. So it's very old, without going into detail about it, but what it basically does is it shuts down the body because predators see movement. They do not see form as much as they see movement. Now, mammalian predators can be a lot more, they have a lot more complex ways to hunt. But the bottom line is this part of the nervous system is based on the principle that predators do not see movement. Therefore, the freeze state is actually an outstanding technique to avoid danger. What happens is this old part of the vagal nerve, which is also what's innervating our gastrointestinal system, basically shuts down, and that's when we get, when you talk about, pardon my language here, scaring the shit out of me or scaring the piss out of me, what we're talking about is actually the vagal system or the dorsal vagal system in the freeze state is just shutting down your GI tract and getting rid of that stuff because you need that energy. You need to store energy. You don't need to digest things. So that's what we're talking about, is that complete sort of loss of activity in the metabolic system. It's important to say that if if flight is anxiety and fight is anger, freeze actually represents more of depressive states, dissociative states, or you've heard that saying, paralyzed by fear. It can actually represent like a terror state. So remembering that when we see our patients, and that classic is that patient, it doesn't matter how many antidepressants you give them and how many ancillary, woo-woo therapies you give them and how much therapy they've had, they cannot come out of the depressive state. We may very well be looking at this sort of chronic, ingrained freeze state. Remember then with this that our patients have disordered eating behaviors because they are a defensive strategy. They are helping patients manage this high level of sympathetic activation. So when we ask them to give up these behaviors, we are actually asking them to go into a hyper-arousal state. We already know that they're in it, but we are really asking them to put themselves for what their body experiences as risk and in a state of being threatened. We're asking them to endanger ourselves. So what we think is a reasonable, you should do this or you shouldn't do that, to them on an unconscious and on a physiological level, they hear it as, you need to make yourself vulnerable in order to get better. They're not going to hear that as a positive experience. Hold on, there we go. So I just want to touch on here the concept of forbidden feelings. There's my slide. What are forbidden feelings? Those are the feelings that are not allowed to be expressed within the family. Those feelings escalate family conflict and anger. Expressing them becomes a threat to the safety of the child. For example, a 5-year-old can't walk up to Daddy and go, "Daddy, when you come home drunk, I feel scared, angry, and hurt." What's Dad going to do? He's drunk. Whack! So the kid can't express their feelings because to express their feelings actually puts them in more danger. What happens, though, is those feelings are there and they need to be expressed. So they become expressed in indirect or surreptitious sort of ways, and recognize that food is very much a surreptitious way of expressing an emotion. First of all, it can, eating can soothe anxiety. Eating is going to release a lot of, shall we say, unleash a neurochemical process whereby the child has that sense of being sated and the parasympathetic nervous system is activated, and it's going to recapitulate the experience of actually having soothing others to take care of them. They may not really have that, but they can create it, right, by eating food. It shuts down the sympathetic and it turns on the parasympathetic. They're not going to be, they can act out anger by refusing to eat, just as well. It's sort of the early developmental equivalent of, I won't eat and you can't make me. So food has a way of becoming a resource to express or manage feelings that are not otherwise allowed. Of course, the problem with that is the food can also become weaponized, so that it becomes a punishment for the child. Your sister can have a chocolate chip cookie, but you can't have one. And then for the kid, it can become a way of resisting and protest defiance against overbearing parental control. So an important question when we're dealing with these patients who we're trying to get them to eat and they don't want to do it is, what is the emotional content and the psychological meaning of their behavior around food? Because if we can appreciate that, and I'm using the word appreciate because we must feel empathy for our patients. If we can appreciate what that food means to them, then we can at least be a little bit less reactive and more nurturing in our response to them. And we all know that eating disorder patients can be very frustrating, so anything that can help us be empathetic is a positive. When we look at using food as an external soothing resource, again, food is a signifier that represents intrapsychic, that is the internal life of the patient, as well as intrafamilial, those within the family, and interpersonal, one-on-one relationship conflicts. So the food can be sending a message or having meaning within any of those contexts that is helpful for the patient. Again, the food activates the parasympathetic system, which probably relieves some of that sympathetic hyperarousal. Also, remembering that starvation, binging, and purging create a lot of metabolic changes, whereas it can create beneficial affective states. So it can, if you're starving to death and your brain ain't getting enough food, then, it's a good thing to not, to shut your brain down, to starve it, because it can basically go into a dissociative state or withdrawal state. Same thing with anxiety. It can create or soothe it, or it can sustain a fight strategy because remember, anger is kind of that's our life energy there. If I'm pissed off, then I'm going to fight for my life. I want to go next and look at some of the developmental things. I've got Freud up here. I realize Freud has lost some of his popularity, but I want to come to this because he recognized oral, anal, phallic, latency, and genital stages. If we look at the first three, oral, anal, and phallic, basically what this means, this is not about being anal expressive versus anal retentive or whatever. What it means is that these stages, oral, from birth to 18 months, is the primary area of sensory focus, of sensuality, not sexuality, but sensuality, is around the mouth. And the child is learning to utilize their mouth, and they can use it both for feeding purposes, but they also find out they can use it for babbling purposes. And if they babble, mommy babbles back. And if they smile, mommy smiles back. And mommy is happy. And what could be better for a baby than a happy mommy? So they also are using their mouth to explore their environment. So they're putting their fingers in their mouth and their toys in their mouth and so on. It's actually quite an exciting thing to have in your body, this magical mouth thing. When we look at Freud's anal stages, we're talking about, that period of time, which is, where they're developing toilet training as a primary goal, but it's really actually about they're learning all kinds of motor skills. Control of their rectal sphincter and their urinary sphincter is one set of muscle control, but they're learning all these wonderful muscle things with their bodies that they can do. Phallic stage, again, it is not a sexuality issue. Phallic, Freud was Victorian, we're kind of stuck with some of his language choices, but the point of the phallic stage is that this is a point in time where the child is recognizing their genital region as an interesting place. It's erogenous, but it's not sexual. This is just about the process of discovering their body. When we move into latency, which is basically elementary school, what's happened then is that the process of discovering the body has been done, and now what they're doing is they are consolidating all these skills, both emotional, psychological, and physical, that they've been learning in those previous 6 years or so. They're consolidating. The body is less of an issue than it was earlier, because now what they're learning to do is that they're a good piano player, or that they suck at math, or whatever it is. They're consolidating the lessons learned. If we talk to most of our ED patients, why does this matter? It's because if you actually talk to them, they have a hyper awareness of body and dieting and all that sort of thing during this school age period, and it may not be manifesting as an eating disorder, although sometimes it does. But nonetheless, these are things they shouldn't be thinking about. And the fact that they're thinking about them means something went wrong a lot earlier. The genital phase is just what Freud called the sort of maturation of, the awareness of genital sexuality. And so this has to do with the kinds of developmental tasks that we have in adolescence and adulthood. There we go. Okay. I want to superimpose on that Freudian system Eriksons' biopsychosocial model. The first was trust versus mistrust. This is 0 to 18 months. That's Freud's oral phase. And I'm going to go over the specifics of what's happening there in a minute, but I want to point out that the Eriksons' autonomy versus shame and doubt is the equivalent of anal, initiative versus guilt is preschool. Phallic, and industry versus inferiority. I'm sorry, I realized I just made a mistake. Stage 3 is preschool, and stage 4 is elementary school. This may seem like a lot of useless, academic stuff, but this is about understanding how our patients came to be the person that they are. And one of the things that we can do is we can look at the behaviors or the defensive systems that are manifesting, and it can tell us a lot about perhaps developmental insults that they had when they were younger, which actually helps us understand a little more how to deal with them. Because the truth is if developmental insults occurred in a pre-verbal stage, they're not going to have words to describe it. I had a patient who was referred to me by a therapist that I knew, and this was her oldest daughter, and her oldest daughter was a compulsive overeater. The therapist was a very talented therapist, but was also very eating disordered herself, only she was a restrictor. So one day I was listening to my patient, and she was talking about how she always had to have food in her purse. And I just commented to her, I said, wow, it sounds like you're always afraid of starving to death. And she burst out crying, and she told me the story that when she was born, her mother's first child, remember this is an eating disordered mother, her first child, that her mother tried to breastfeed but was not producing milk. Only the mother didn't realize it until 2 months down the line when she brought her starving, malnourished child to the pediatrician and said, she's crying all the time. You know, the problem was identified and repaired, but think of that. An eating disordered mother could not even recognize whether her child was being nourished because her own issues were in the way of her ability to recognize hunger and need in this child. So there's something that this patient could have never known, right? She wouldn't know, oh, I guess I'm always starving to death because, gee, I was always starving to death. She doesn't know that. She just knows that she always is in fear of starvation. I've got the slide up now for some later stages of Eriksons biopsychosocial model, which is basically looking at adults and adolescents. So the job of a teenager is to develop a sense of who they are versus who the other person is, which is complex in teens because they both want to belong and they want acceptance, but they also want to individuate. Another thing that's going on here is, of course, adolescents are going through puberty. And then stage 6, we're looking at young adults where their job is to learn how to develop bonded, loving relationships with a specific other. You know, we're looking at love relationships, whereas adolescents, stage 5, we're looking more at the general social relationships. I'm going to skip the others because most of our patients are going to present earlier than those age groups, but not always. So there we go. I'm going to skip this because I recognize there's a time issue, but the important thing on this slide is that Erikson recognized that any child or person who successfully navigates a given stage will develop positive outcomes, or if they're unsuccessful, they'll develop negative outcomes. And the thing is here is you can develop the positive outcomes. So, for example, in trust versus mistrust, stage 1, the child has to learn how to trust. I need to trust caregivers because I can't take care of myself. So I need to trust in your best intentions as well as in your competence. So if that's what the child learns, they can progress further, and actually we're probably not going to see the kind of eating disorder problems in that population. However, there can be the extreme of that positive outcome, which is, I want to say, the trust without verification, so that they become overly trusting and they take chances with people because they cannot differentiate between a safe and an unsafe person. So that's what I mean when these things you can take anything to the extreme, whether it's a positive or a negative outcome. If it's the extreme of the positive is also a negative because it impairs their ability to function successfully. So what I'm going to do here is just, I'm listing a lot of stuff up here which you can write down or you can Google it because that's why God made Wikipedia. But what I'm just going to do is talk a little bit about this trust versus mistrust, which is an oral phase process. Oh, actually, I'm looking at my clock, and I realize I'm coming away from time. What I want you to think about, and I'm going to suggest that you go ahead and do a little reading on this, and it doesn't have to be in depth, but it's to understand that, for example, in an oral phase, what am I learning to do? I'm learning to trust others to feed me. I'm also learning that I can tolerate delayed gratification. If I cry now and it takes 10 minutes for mommy to feed me, I can tolerate 10 minutes. It's also where the child is recognizing the difference between self and other. It's me, and it's my mother and my mother's breast, but she's not me. I cannot control my environment. So this is an important developmental process. If we look at anal phase, it's not just about toilet training, controlling sphincters. It's about developing a skill around the internal capacity to manage conflicts between immediate gratification, I'm going to poop in my diaper, and delayed gratification, I'm going to poop in the toilet. This is also a time when children are learning autonomy and independence. So, the terrible twos, no, you can't make me. And whether it's food or putting on your shoes or whatever, okay, that's a normal child process that every parent has to tolerate. But if you have a parent who cannot tolerate autonomy and independence of their child, that needs to stay in that much more primitive and meshed bond, then you're going to have a lot of problems that your patient is going to show up and they're probably toilet trained. But how are these conflicts from their early childhood manifesting? I am going to just, again, because of the time issue, I'm going to skip some things, but I just want to talk about one more thing, which is when do we see, and let me find the slide, when do we see eating disorders manifest? Well, the classic is puberty, and and then again at young adult, sort of college age. And actually, we're now seeing this cohort of patients being diagnosed much more in middle age. If we look at those things, and I am moving through these relationships or these things. Okay, here we go. I went one too far. What are the hallmarks of these periods? Well, 10 to 12 years old, what's happening? Puberty. They're developing sexuality. If they are not comfortable in their body because they never learned that their body was okay and comfortable, how are they going to manage all these amazing changes of sexuality that they are not physically or emotionally prepared for? The other thing that's happening at 10 to 12 years old is that they're moving from a primary social experience of the family into the larger community, into their friend groups. So this is a period, 10 to 12, when we're looking at sexuality and autonomy, something that these kids have been having struggles with probably from very, very early in their lives. Next is 18 to 22 years old. What's happening? They're moving away from home. They're going to college. They're getting a job in their first apartment, whatever they're doing. And they are actually now able to experiment in a much more adult way around their sexuality. So it's not safe from the experience of autonomy. They're not able to fully be independent. They're trying to be independent through eating behaviors, but psychologically they're not independent. Same thing when we look at 18 to 22 years old, and now that we look at these middle-aged women as a cohort, first of all, it was probably there all along. It just didn't show up until their parents died. Their children went away to school or went to elementary school. They're going through menopause and their sexuality is changing. So recognize that a lot of times eating disorders function to help people cope with women, but also men, to help them cope with issues around sexuality and autonomy. So what's that? Okay, so we're going to do a Q&A for now, and again, I know I ran over. I'm sorry, but I'm open to questions here.
Thank you very much, Dr. Moyer, for a very informative presentation. We have had a number of questions from the audience that have already come in. We also like to remind those of you on the program that you can still submit a question by using the Q&A area below the slides, and we will try to get through as many of these questions as possible in the time we have remaining. Dr. Moyer, a question came in that asked, what therapeutic interventions have you found helpful in controlling impulse overeating once that disorder is very established into adulthood?
And just so I'm clear, just overeating, or are we talking about eating behaviors in general?
I think in this case it was specifically about impulse overeating.
Impulse overeating.
Yes.
Well, again, you've got to approach it as a global issue. It's a learned behavior. It is a soothing behavior. It gives them a sense of autonomy and independence. It's deactivating that sympathetic activation. As a psychiatrist, that's a patient I might look at and say, do I need to be giving them a beta blocker or an alpha blocker, something to quiet down that nervous system? Very specifically, not necessarily a benzodiazepine. A benzo will sedate them, but it won't necessarily quiet down that sympathetic system. So one of it is looking at, is the impulsivity related to an anxiety or an agitation state? Because if it is, then I can treat that neurochemically, but also the therapist who does CBT or DBT can approach it from examining the timeline that pre-existed the behavior, not once the behavior was initiated, but what led to the behavior. So that's an abbreviated answer, but I hope that helps. People need to be conscious. Remember, defensive strategies are not conscious. They are reflexive, and they need to be brought into the consciousness in order to have healthy defensive strategies.
Very good. Another question was, how do parents and grandparents of preteens know when to worry about a child who is just often not hungry? What would be some of the maybe signs that would be of something more serious there?
Well, an elementary school kid should not be preoccupied with body. They should not be preoccupied with diet and weight. Now, to some degree, they may have influence from an older sibling or from, TV show du jour, but to look at whether they are comfortable eating whatever they want to eat, but they can contain portions. The other thing is to notice, is my child treating anxiety with their eating behavior? Is my child, and it may be, is my child treating, difficulties in the social milieu? It's really more about being aware, attuned to, and empathetic to the internal life of the child. If parents didn't grow up with, attuned parents, they're not going to be attuned parents. But if they're bringing that kid into the office, they want to be attuned to it. So that's where working within the family system becomes helpful, because it can stabilize relationships with the parents. And if there is a stable relationship that is safe and soothing with parents, the child will be able to move into older stages of, or the tasks of development in an older stage, adolescence, for example, but knowing that they have that safe resource at home.
Excellent. Another question that's come in said, if you had to guess, what percentage of patients that you see have substance use issues in addition to an eating disorder?
I can't tell you a percentage, but I'm going to say that it's very high, and this is why. What I said before, children will find what works, but they're going to choose from a child's toolbox with a child's insight, which is virtually nothing, right? So anything that soothes that sympathetic state of hyperarousal is a legitimate choice. So they're using sex because they get a sympathetic discharge and they actually get a dopamine and an oxytocin release from it. They're going to use drugs and alcohol. They're going to use food, and they're going to use compulsive exercise. Anything that soothes that hypersympathetic arousal state is fair game to a child who has no internal self-soothing or coping mechanisms.
Excellent. And Dr. Moyer, to wrap up, we went through a lot of material, obviously, in this presentation. I'm sure there are some unanswered questions, and you have a lot on this agenda. Could you give the audience your contact information for them to be in touch if they have further follow-up?
Yes, I am available through Sierra Tucson, which is 520-624-4000, and you can ask for Dr. Tena Moyer. But I'm also going to give you my cell number because I am not always on campus, and it will not be an intrusion if you want to call or text. That number is 520-907-5713. There's the typical call the emergency room if this is an emergency, but you can hit pound and it'll go past that right to message. The other thing is I will give you my email address, and I'm also giving you my personal email address in case I missed something at Sierra Tucson. It's Tena Moyer, one word, TenaMoyer, Tena with an E, at gmail.com. If you don't hear back from me, just feel free to call me again because it might get lost in my disorganized mind. I very much want to thank you all for joining us. I hope this has been helpful, and please feel free to contact me or Sierra Tucson if you have any further questions or concerns. Thanks.
Thanks so much, Dr. Moyer. Really appreciate it. That is all the time we have for questions today. I now have some final instructions to pass along regarding CE credit. Again, do not leave the console. The site will automatically redirect you to a survey at the conclusion of this presentation. This survey must be completed in order to generate your CE certificate. For those watching in a group, as a reminder, please download the group submission guide in the Resources tab to the right of the slides and follow the instructions provided. Please note again that CE credit is not available for the archived webinar. It is only available for the live event, February 15th, 2017. If you have any questions, please click the red Help button to troubleshoot the issue. I want to thank Dr. Moyer once again for an excellent presentation today. I also would like to thank Sierra Tucson for making today's program possible. Finally, thank you to our audience for participating today. We hope you will join us in the future for another Addiction Professional webinar. This concludes today's presentation.